Hello, I'm Helen Oxenham. I'm one of the cardiology consultants. I work at North Tees Hospital. I've been a cardiologist for about 30 years and I specialise in imaging and valvular heart disease, and I also do adult congenital heart disease. Mostly I do echo and transesophageal echo. They're my the things I do the most. But I also do CT, coronary angiography, and assess the heart with CT. In the past I've done some MRI. So that mission was the second time that Joel and Enoch had gone to Kumasi, and in between those two missions, the team from Kumasi had come to James Cook and North Tees and had been trained for a month in cardiothoracic surgery and pacing. So the real aim for all these missions is to establish pacing in Kumasi, which has already occurred. The cardiologists there are able to put in pacemakers independently, and this mission, Justin is there to consolidate that training and also expand it into doing box changes. And then the other part of the mission is to establish a centre for cardiac surgery, particularly valvular heart disease, because there's a lot of valvular heart disease in Africa because of rheumatic fever. It's the most common cause of death in people cardiovascular death in people under the age of 25 in Africa. And it can be prevented. Whilst it can be prevented with antibiotic prophylaxis on a population scale, people still get it. So there's still a need for the operations to happen somehow. So that's the main purpose. I'm obviously not a surgeon, so I'm not going to be doing that part of it, but my role is to find the patients and make sure they've got the right diagnosis. There's no point in putting a new valve in someone if they don't actually have valvular heart disease, and that's where echo is so important, because if the echo says, oh, this person's got mitral valve prolapse, for example, one of the patients today, the cardiologist thought the patient had mitral valve prolapse, that's a person that could have a mitral valve repair operation. But actually they didn't have mitral valve prolapse, they had mitral valve abnormality due to rheumatic fever, and that's the kind of abnormality that you would have to put a new valve in, so it's a mitral valve replacement operation. So you need to know that beforehand, because you need to have the right kit to do the right operation, and you also need to know other things. For example, apart from rheumatic fever, rheumatic heart disease in Africa, there is actually also a lot of adult congenital heart disease. So this trip we've had a lady who's about 30 who's got a very large ASD, which will need to be closed. Another lady who's got a VSD, which is another hole in the heart, and that's causing her heart to be enlarged. That can't be left because it will significantly shorten her life. So those are other types of operation that can be done and should be done on particularly young people. But in order to make the diagnosis, you have to have echo scanning. And whilst a lot of the echo scanning in Accra has been very good and accurate, it's important that as much echo and as many people are good at echo and understand echo as possible, so that they make the correct diagnosis, so that they can tell the surgeon what they need to know, so the surgeon can plan the right operation. And also during the operation, it's really important to do scanning of the heart, so that complications or abnormalities in the valve are identified before the operation is completed and finished, so that when the operation is finished, you know that the valve is competent and it's working properly. So echo is important all the way through. So in Ghana, echo is completely different to in the UK, in that most of the echo is done by cardiologists, so the doctors do the echoes, whereas in the UK, almost all echoes are done by cardiac physiologists, cardiac sonographers. So that's one difference. The echo, so for example here, I haven't met any cardiac physiologists. All the echo seems to be being done by the consultant cardiologists. And certainly the echo that I've seen is very good, but the breadth and the ability to say to someone, oh, what do you think of this, is perhaps not there. So we all benefit from showing each other echo scans and saying, what do you think about that? And it's really supportive to be able to do that, and it helps people learn and gain experience. And if someone's seeing people on their own and doing their own scans, then maybe don't get as much of that sort of QA and feedback on their practice, so they wouldn't know if they are doing an echo incorrectly or not. Certainly the echoes that have been done on the patients here have been in general mainly correct. So there seems to be relatively good numbers of cardiologists. The whole system is completely different to the UK because it's a private system. We're only seeing the people who can afford to A, see a doctor, B, pay for an echo scan or see a specialist, and then C, potentially pay for additional treatment after that. So we're seeing the very tip of the iceberg. And one of the things that we had started thinking about when we were up in Kumasi was screening the population with echo to find some of the other patients, because not everyone needs a heart operation. We had a patient this week in Accra who'd come from the north. He's 10 years old, and he was felt to have very severe mitral regurgitation, and the doctors thought he might have had endocarditis and that he needed an operation. But actually he had rheumatic heart disease and the natural history of that is that the valve can get less regurgitant over a period of time. Not always, but sometimes they can get better over time. And we were able to see that boy just do a transthoracic scan, show that the regurgitation is still severe, but importantly also take a history. It's not just the imaging, you need to also assess the patient. If the patient has no symptoms and no evidence of heart failure, they don't need an operation, but they do need to be followed up. So this boy is playing football, his mother says he's a lot better, he's on medication, he will need an operation at some point, but the timing of it is important, because if he can grow a bit bigger, then that's going to be a more successful long-term operation for him. So not everyone who gets seen will need an operation. Sometimes people present really late and they can still have a treatment. They can have tablets and medication that can improve their quality of life. They don't all have to have an operation, which is why the echo side of things is a much broader than the surgery. So being able to scan larger numbers of people easily is an option to try and find more of these patients. And one way to do that is to use some handheld echoes. So an echo machine, a proper one, costs many thousands of pounds, £100,000 for a brand new top range echo machine. And the problem is that even if you get the echo machine, it can go wrong or break, and then there isn't the people who can fix it in Ghana. So you can now get handheld echo, you can download the images, and you could send the images to a cardiologist in the UK who could look at them and interpret them for you. And there's therefore the possibility of doing echo in very much more remote places. You don't have to have an electricity supply, it's battery operated, and the potential is there to be able to scan people. I mean, certainly the people that have been identified in order for us to see have got relatively severe valvular heart disease. In Kumasi, we saw quite a few people who couldn't have an operation, they were too unwell, so they were even worse. But the population, the group of people we're seeing is very selected, so it's really difficult to know exactly what else is out there. I think the other thing that I've noticed is that people definitely describe their symptoms totally differently to in the West. So they don't really describe breathlessness or chest pain on exertion, that kind of thing. It's very much more about feeling weak or tired, and that's not the kind of language that we use. And each population will use their own words for describing symptoms, and that's something that I think you have to just be in that culture for longer to understand. How do you actually assess people's symptoms? I think that is different to how I would assess someone's symptoms in the UK. So we're really fortunate that a couple of the cardiologists are interested in scanning and improving their echo abilities and doing transesophageal echo. They don't have a TOE probe, but they do have an echo machine which will do TOE on it, so that's really good. I think it would be really interesting to see whether we can look at what options there are for CT in valvular heart disease, because if you've got slightly older people in the UK, normally they'd need to have an assessment of their coronary arteries before they have their valve operation, and that's just to make sure that they don't have a heart attack during the operation. And in order to take pictures of the coronary arteries, in the past we used to do an invasive test called a coronary angiogram, and that involves catheter lab, catheters, dye, and lots of different members of staff. Now they have got a fantastic catheter lab here, but all of that is quite expensive. You need lots of people to do an angiogram, and there's a risk to the patient. You can take the same pictures using a CT machine, and they have got a 128 slice CT machine here, which should be good enough to be able to assess coronary arteries. It's one non-invasive test. It only requires a radiographer and a reporter, usually a radiologist. So it would be really interesting to see if we can look into whether that's also going to be possible here. We did a CT yesterday on a patient actually from the north of Ghana who's got a very large aorta, and if you've got a very large aortic root and you put a catheter in, it's far more difficult to find where the coronary artery is, but also there's an increased risk that you could cause a dissection. So he had a CT scan, and it was with contrast, and we tried to get a gated scan, and it did show us enough to know that what the surgeon would need to do for his operation. So it showed us where the coronary arteries were, it showed us the extent of the aortic dilatation, and it also showed us that there was probably no important coronary artery disease in the proximal coronary arteries. So he's avoided that invasive test, and he's got the information that the surgeon needs to do an operation. I'd like them to be more aware of echo and its value in assessing patients before surgery, showing which patients don't need surgery, assessing patients during their surgery, and also assessing patients after surgery. So the handheld ultrasound that we've used in an intensive care unit, you can scan the heart. It shows you if the patient's got cardiac tamponade, pericardial effusions, pleural effusions, what the LV function's looking like. It's very easy to use. You could train up nursing staff to use it potentially, but that's the kind of thing that would be really good to try and get echo in every step of the patient journey. So when I tell people about what we've been doing in Ghana and explain the situation in terms of what's available to people in the country, they're quite astounded that, you know, if you had complete heart block and you needed a pacemaker, you couldn't get one in the whole country. And so we've been able to establish pacing in Kumasi. And so it'd be really good to be able to keep building on the experience and providing training for the staff in Ghana who are very able and want to provide healthcare for their population. And we're hopefully helping them do that, and to be able to keep coming and doing these missions. It would be great if people felt that they were inspired by this story, that they could give some money to Arrhythmia Alliance Hearts for Ghana charity, because that will allow us to keep establishing and building on our links and improving the services that are available for the people of Ghana.